Okay, Assalamu alaikum. Today's lecture is about the sexually transmitted diseases. Now, what are STIs? These are basically the infections that are spread from person to person through intimate sexual contact. And they are dangerous because they can be easily spread, and it's hard to tell by looking who has an STI. It's important for women to be, in pregnancy, to be checked for STDs because when the woman goes into labor, it may be because of the STDs and may complicate delivery as well. And they can be vertically transmitted as well from mother to baby during the pregnancy, childbirth, or even after the baby is born. Okay, so there may be stillbirths, low birth weight, neurologic problems, but there are treatments to minimize these risks. So it's important to uh, find out. Those diseases that are maternal-fetally transmitted are HIV, herpes, gonorrhea, chlamydia, and syphilis. STDs of concern, actually all of them are of concern. There are certain that present with ulcers and some that do not present with ulcers. Ulcers, commonly called as sores, are seen in syphilis, genital herpes. They're uncommon in other conditions, but like lymphogranuloma venereum, chancroid, and granuloma inguinale, which are common, but they're not present in every part of the world. Then there are certain STDs which do not present with ulcers, rather than they present with drips or discharges, like gonorrhea, chlamydia, non-gonococcal urethritis, trichomonas vaginitis. Then other major concerns are of human papillomavirus, because especially the types 6 and 16, because they can be the precursors for cervical cancers. Now, the genital ulcer diseases can be divided into two types again, the painful and the painless. That is, those ulcers that are painful and those ulcers that are painless. Chancroid and genital herpes ulcers are painful, whereas syphilis, lymphogranuloma venereum, and granuloma inguinale ulcers are painless. First, we'll talk about syphilis, which is the most common and most important type of sexually transmitted disease. It's a spirochetal disease. That's a type of bacteria. Complex sexual transmission, highly variable clinical course. Treponema pallidum causes this, which is part of the member of spirochete. No natural reservoir is found, and organism cannot be cultured from clinical specimens. It's a spiral-shaped bacteria, motile due to the flagella present in it of variable length. Now, the primary syphilis organism enters directly through the skin or through mucosal tissue. Then it is carried by blood throughout the body, and the organism remains at the site, then begins to multiply. The primary lesion is called as chancre. After an incubation period of 10 days to several months, this lesion appears at the entrance site, and it begins as a small singular nodule, enlarges, the overlying epithelium becomes necrosed, resulting in a painless ulcer. Unlike other bacterial infections, there is no formation of pus unless a secondary bacterial infection sets in. So it's a clean-cut ulcer. And it is most commonly seen on the external genitalia. In the women, it may be present on the vagina or in the cervix, and in men, it may be inside the urethra, resulting in a serous discharge. Since it is painless, the patient often does not feel it, and it heals spontaneously after 1 to 5 weeks. Swab of the chancre, when you smear it on the slide, under the dark field microscopy, you'll be able to see the spirochetes. 30% serology becomes positive after 1 week, and after 3 weeks, 90% becomes positive. This is a lesion which shows the chancre, and it is asymptomatic, so it often goes unnoticed. Then the primary chancre can be extragenital as well. This is dark field microscopy showing the spirally arranged spirochetes. This is from the fluid from the chancre. Spirochetes in the blood. You can see the spirochetes, even found in the umbilical cord. Then secondary syphilis occurs 6 to 8 weeks after the initial chancre, and it becomes systemic, patient highly infectious, characterized by localized to diffuse mucocutaneous lesions, often with generalized lymphadenopathy. Primary chancre may still be present. and serology now becomes nearly 100% positive. A widespread eruption resembling psoriasis or pityriasis rosea occurs, which involves the palms, and and such lesions on the palms should definitely be the differentials for secondary syphilis. Then secondary syphilis lesions on the back. Then the latent, the stage of infection in which the organism persists in the body of the infected person, but the patient has no symptoms. He becomes asymptomatic, and this stage may last for years as well. 1/3 of these untreated latent stage individuals can go into tertiary syphilis. And after 4 years, it is rarely communicable sexually, but can be passed from mother to fetus. Then this stage may be further subdivided into the early latent within last 1 year, and the late latent, in which the initial infection has occurred greater than 12 months before, and the latent of unknown duration when you actually don't know when was the initial infection. Tertiary syphilis is divided into 3: the gummatous syphilis, the cardiovascular, and the neurosyphilis. Gummas are localized areas of granulomatous inflammation which are found on the bone, skin, and subcutaneous tissue. And the cutaneous gummas may be single or multiple, generally asymptomatic and grouped together. The visceral lesions may often cause local destruction of the affected organ. Obviously, then the function of the organ may also be affected. And the gumma contains a lymphoma, lymphocytes, plasma cells, and the perivascular inflammation. This is a picture of a bubo, which when breaks down, gives rise to a gumma. Right? This is also a gumma of the tertiary syphilis. Then the tertiary syphilis has cardiovascular findings as well, and these usually occur 20 years or more post-infection. Usually involves the aorta, and the invading troponines can be seen scarring the tunica media. Over many years, the inflammatory scarring weakens the aortic wall, leading to aneurysms, and this causes incompetence of the aortic valves. Antibiotic treatment cures the syphilis infection, and may stop further progress of the cardiovascular syphilis, but one damage, once it is done, it cannot be reversed. Neurosyphilis caused by invasion of the organisms into the CNS manifests as an insidious but progressive loss of mental and physical functions, accompanied by mood alterations, forgetfulness, personality change, psychiatric symptoms, and neurosyphilis occurs 10 to 20 years after the primary infection. The treatment will not improve the symptoms. Neurological complications include generalized paresis of the insane, stapes dorsalis, degeneration of the lower spinal cord, and neurosyphilis can only be diagnosed serologically by VDRL. Cerebral atrophy, which is most prominent in the frontal lobes, is seen in the generalized paresis. Congenital syphilis is transmitted from mother to fetus. Fetus affected during 2nd or 3rd trimester. 40% results in syphilitic stillbirths. Fetal death occurs, stillbirth or fetal death that occurs after 20 weeks gestation, and the mother had untreated or inadequately treated syphilis at delivery. According to the CDC, 40% of births to syphilitic mothers are stillborn, and 40 to 70% of the survivors will be infected, and 12 of these will subsequently die prematurely. Death from congenital syphilis is usually through pulmonary hemorrhage. Congenital syphilis may show bone deformities, blindness, deafness, deformed faces, dental deformities, skin rashes, and neonatal death. Live-born infants show no signs during the first few weeks. 60 to 90% develop clerohemorrhagic rhinitis, skin eruption, especially perioral, and then on palms and soles of feet is common. Other signs include generalized lymphadenopathy, hepatosplenomegaly, jaundice, anemia, painful limbs, and bone abnormalities. Congenital syphilis. Early onset syphilis manifests at birth or months after, exhibiting a diffuse infiltration, scabs and fissuring along the periphery of the mouth, ragates of mouth, and these leave sulci in a radiated pattern or ragates. Clerohemorrhagic rhinitis, rhinorrhea, very severe. Skin eruptions, especially around the mouth, palms of hands and soles of feet. Then Hutchinson's incisors are typical for congenital syphilis. These are peg-shaped or barrel-shaped incisors. Then the diagnosis of syphilis is based on the evaluation on three factors: the clinical findings, the demonstration of spirochetes in the clinical spectrum, the presence of antibodies in the blood or CSF. And more than one test should be performed because no serological test can distinguish between other treponema infections. Then laboratory findings, direct examination by dark field microscopy of the fluorescent antibody testing. Then non-specific or non-treponemal tests and the specific or treponemal antibody tests. Non-specific are basically screening, and the specific treponemal tests are for confirmation after a positive reagent or screening test. Non-treponemal tests include the VDRL, RPR, ELISA. The VDRL is basically a flocculation test, and it may be false positive, but you have to confirm it with the reagent tests. Rapid plasma reagent test, or the RPR, it cannot be performed on the CSF. Reagent screen test, it's a modified VDRL, and macroscopically visible flocculation reaction is seen. Specific treponemal tests are performed to confirm a positive non-specific test. Treponema pallidum immobilization test, treponema pallidum heme agglutination test, and the fluorescent treponemal antibody absorption test, and ELISA. TPI, or treponema pallidum immobilization, is the prototype. It's the gold standard, but it's cumbersome and expensive and is no longer used. Treponema pallidum heme agglutination is agglutination of the RBCs as a positive test in this. FTA-ABS is a fluorescent treponemal antibody absorption test, highly sensitive and specific but time-consuming. Then second is after syphilis is chancroid. It's called as a soft chancre. It's an acute infectious disease of the genitalia caused by a gram-negative bacillus, the Haemophilus ducreyi. Incubation period 3 to 7 days. One or more small red painful papules or pustules appear, rapidly break down to form multiple round or oval ulcers, and these are painful, have ragged edges and sloughing bases, bleed easily on touch. They are soft and non-indurated as compared to syphilis. This is a picture of chancroid. 1 week after the appearance of the ulcer, the inguinal lymph nodes in one or both groins may become enlarged and tender, and they become matted, forming an oval mass, which is called bubo. Then suppuration commonly occurs, and in untreated patients, the skin will break down, leading to sinus formation and discharging pus. Spreading gangrene to the external genitalia, hemorrhage from an ulcer, urethral stricture, fistula, phimosis, and paraphimosis, sinus from lymph nodes discharging pus are common complications. Clinical picture: gram stain smears reveal small gram-negative bacilli in the form of appear correct, and they're usually in the form of chains of pairs, giving the appearance of a school of fish. This is a picture of the school of fish, and this is the appearance of Haemophilus ducreyi collectively seen. Then there are differential between chancroid and chancre on the basis of causative organism, incubation period, number of lesions, consistency, base, regional lymph node enlargement, VDRL positivity, and the treatment. Azithromycin, single dose. Ceftriaxone, single dose. Ciprofloxacin, 3 days. Erythromycin, 7 days. So these can be easily treated. Then lymphogranuloma venereum. It is caused by Chlamydia trachomatis, types of L1, L2, L3, usually transmitted by the sexual contact. Incubation period 1 to 4 weeks. Clinical picture: papulovesicle develops, rapidly turning into a transient ulcer which heals rapidly. Then there are inguinal syndrome, in which the inguinal lymph nodes become enlarged and tender, they matted together, and their sausage-shaped mass is called as climatic bubo. The nodes eventually break down with the abscess formation, and rupture of the skin leads to multiple sinuses. The inguinal ligaments and the groin fold divides the glands into upper and lower groups called as the groove sign, more common in men. This is a groove sign. You can see the depression or groove present between the two groups of lymph nodes. Then the rectal syndrome, which is more common in the females, proctitis, rectal stricture, perirectal abscess, elephantiasis, induration, and slow development of enlargement of the penis and scrotum, called as saxophone penis in males. And estheomene is the edema and enlargement of the vulva associated with ulceration, fistula, and scarring of the buttocks and thighs. Urethral stricture and fistula may be seen. Clinical picture smear has to be taken, or GIMSA staining, complement fixation, culture. Treatment is very simple: doxycycline twice a day for 21 days, or erythromycin 4 times a day for 21 days, and aspiration of the fluctuant lymph nodes to avoid rupture. That is granuloma inguinale. It is a chronic progressive granulomatous disease affecting the skin and subcutaneous tissue of the genitalia, perineum, and the groins, caused by dormant bodies or dormant granulomatous, and are called as Calamatorbacterium granulomatous. Incubation period is uncertain, 8 to 80 days. A red painless papule appears on the genitalia in the pubic or inguinal region. It's painless and grows slowly to produce a chronic granuloma. The lesions are beefy red in color and raised above the surface. The granuloma advances slowly, destroying the tissue lying in its course, and the regional lymph nodes are not enlarged, so it's a pseudobubo. This is a picture. Another picture, kissing ulcer. Complications: secondary infection, rectovaginal fistula, urethritis, cystitis, genital edema. Clinical picture: the stained for the diagnosis, then the stain smears with Wright's or GIMSA stain will show the organism. They appear as encapsulated rods with pink capsules on the borders, bipolar distribution, and condensation of chromatin material, giving the appearance of a safety pin. This is a safety pin. This is, you can see the appearance of a Klebsiella granulomatous dominant body, safety pin-like appearance inside the monocytes. Treatment: doxycycline, azithromycin, ciprofloxacin, erythromycin, or trimethoprim sulfamethoxazole. Then gonorrhea. Neisseria gonorrhea, which is gram-negative diplococci, most common organism. This is the organism causing diplococci gonorrhea. Male to female transmission is more than vice versa. Primary lesions site is endocervix, vaginal discharge, frequency, dysuria, abdominal pain, and menstrual abnormalities. Other local infections: rectal, orogenital, Bartholin gland abscess, then pelvic inflammatory disease by the spread to fallopian tube salpingitis, and the pelvic cavity, the peritonitis. Complications of PID include infertility and ectopic pregnancy, then disseminated gonococcal infection, bacteremia with the fever, skin rashes, arthralgia, and non-purulent arthritis, then even endocarditis, meningitis, and purulent arthritis. This is a picture showing gonorrhea, the diplococci, and the purulent discharge, gonococcal cervicitis, ophthalmia neonatorum for the fetus as it passes through the affected vagina. Diagnostic methods: culture and non-culturable with the PCR, gram-stained DNA probing. Pregnant females should not be treated with quinolones or tetracyclines. They have to be treated with the alternate cephalosporins. And if cephalosporin is not tolerated, then spectinomycin 2 gram IV stat, IM stat. So this was about the common sexually transmitted diseases. And you can go through the lectures if you want to, and any query you can contact me. Thank you. Okay, Assalamu alaikum. So this is the last lecture that you should do, because this is basically preparation of the OSCE or the OSPE from all what we have done. You will see one picture, and then there will be details, the questions, and then answers to that. Which disease is this? This is acne. Questions become like, describe the lesions. What is the etiology of the disease? Like, they've not asked the diagnosis, okay? They've just asked the description, then the etiology, what are the management modalities, and the indications of isotretinoin. It's what do you see? Papulopustules, post-inflammatory pigmentation, and some scarring. Then what is the etiology? There are 4 etiologies: retention, hyperkeratosis, inflammation of sebaceous gland, increase in the propionobacterium acnes, and the increase in sebum production. Then what is the control? What is the treatment? Oil control with face washes, then the topical treatment, systemic treatment, and what are the indications of isotretinoin when conventional treatment is not responding, nodulocystic acne, or scarring is present. Similarly, you can be asked about what are the contraindications of isotretinoin. What is this condition? You can assess yourself. You can test yourself this way. This is a tinea infection. You have to describe the lesion. How does it evolve? What are the drugs used for treating it? And any other two sites involved. Annular erythematous plaque with central clearing and slight scaling. So if you know the terminologies, you know the description, you can describe any lesion that comes, even if you don't know the diagnosis. The spread is like a small papule forms, which moves centrifugally. Topical and systemic. Always divide the dermatology treatment into topical and systemic. Other sites involved: scalp, feet, and groins. What is this? This is name the infection. Now they have asked the infection. Describe the lesions, any of the two diseases caused by viruses. So you get a little hint that this is a type of viral diseases. And sometimes you get hint in the questions. So always go through the questions first before starting answering. Management of this infection. Herpes simplex or labialis type 1. Small grouped vesicles. Other viral infections: measles, molluscum, varicella. That is chickenpox. It is self-healing, but symptomatic you can give for topical and systemic treatment and prophylactic. This is molluscum. Description of the lesion, name any two other diseases caused by viruses, and management of this infection. Pearly white lesions with a central depression called punctum. Measles, herpes zoster, and warts. Self-healing in 1 year. Manual extraction with forceps, cautery, and cryotherapy. Now you can see that this is a child having perioral and perinasal lesion. Description of the lesion, what are the types? This is basically impetigo. Honey-colored, dirty-looking crusted lesions periorally and perinasally, caused by group A streptococci, and to Staph aureus causes the bullous variety. Topical mupirocin also in the nose. Systemically, flucloxacillin and coamoxiclave. Other bacterial infections include erysipelas, carbuncle, ecthyma. Then this is a child having face scaling. This is atopic dermatitis. Crusted, scaly, erythematous lesions on face, especially in cheeks, around the mouth in an infant. There are three types: infantile, childhood, and adulthood phase. Seborrheic dermatitis, Pomphylix, asterotic eczema. Then what is the triad of allergy? Allergic rhinitis, allergic asthma, and allergic or atopic dermatitis. Description of the lesion. This is basically seborrheic dermatitis, erythematous scaly lesions in the T-zone of face in an adult. Hormone-related activity of sebaceous glands so occurs after the puberty. Infantile, other endogenous dermatitis include atopic dermatitis and Pomphylix. The only type that occurs before puberty is the infantile seborrheic dermatitis, which is also called as the cradle cap. This is due to the maternal hormone transfer through the placenta and is a self-limiting condition. Then you can see an infant's foot and the interdigital space with the pus present, pustules. This is basically her scabies. Organism is female Sarcoptes scabiei, which is a type of mite. Affects the stratum corneum only. And for the treatment or management, you have to treat all contacts, maintain hygiene. Then the topical treatment, permethrin, and systemic ivomite in resistant cases. Lesion present on the upper back or nape. This is carbuncle. Most common metabolic cause causing the above condition is diabetes. For treatment, you have to treat topically and systemically with antibiotics along with incision and drainage, which is very important. Other bacterial infections include impetigo and ecthyma. This is a dermatomal distribution showing papillovesicular pustules. This is herpes zoster. Pathogenesis is reactivation of dormant varicella zoster infection after the primary infection. Topically acyclover, systemically acyclover, and famcyclover, which is preferable to prevent post-herpetic neuralgia, which is the most common complication. Wheals can be seen. What is the etiology? Localized intracutaneous edema due to release of histamine and bradykinin in response to allergen. Some causes of urticaria: seafood, contact allergy, and idiopathic. Treatment is topical and systemic steroids, antihistamines type 1 and 2, soothing agents, prophylactic montelukast. Avoid the triggers, which is of utmost importance. Then you can see the knees, bilaterally symmetrical, salmon-colored plaques with overlying large scales. This is psoriasis. Other sites are knees. Most common sites are knees, elbows, occiput, sacrum, and scalp. Other types include psoriatic arthritis, psoriatic erythroderma, pustular psoriasis. Treatment is variable: ultraviolet treatment, vitamin D analogs, dark preparations, retinoids, immunosuppressives like methotrexates and cyclosporins. Latest treatment is biologic agents like elefacep, etanercept, interleukin-17 and 23 inhibitors. Then this is a picture showing bullous disorders with the histopathology, as well as the immunofluorescence. You can see a subepidermal blister. Description of the picture: multiple TENS bully on the limbs, subepidermal split, immunofluorescence shows band-like infiltrate on the dermoepidermal junction. Cause for this is bullous pemphigoid antigen 230 and 180. The pathology is in the hemidesmosomes. Treatment is topical and systemic steroids, immunomodulators, but low dose steroids as compared to pemphigus vulgaris. Other types of bullous disorders include epidermolysis bullosa, dermatitis herpetiformis, and pemphigus vulgaris. This is again a picture of another bullous disorder. This is pemphigus vulgaris. You can see the clinical picture, the histopathology, and the immunofluorescence showing the suprabasal split. Multiple erosions, suprabasal split, immunofluorescence showing fishnet or chicken wire appearance over the lower layers of the epidermis. The lesions, the pathology lies in the desmoglein 3 present in the lower desmosomes. Treatment is topical and systemic high-dose steroids. Lifelong treatment needed, immunomodulators. Other diseases include epidermolysis bullosa, bullous pemphigoid, and dermatitis herpetiformis. Then this is lesion press. So you can see raised lesion present over a scar. Description of the lesion, name some types of scars: keloid, hypertrophic scar, and atrophic scar. Keloid extends beyond the margin of original lesion, whereas hypertrophic scar doesn't cross the margin. Laser, intralesional steroids, cryotherapy, surgical excision followed by radiation is a must. This is a picture of, you can see infiltrations present all over the face, leonine facies seen in the lepromatous leprosy. What is the WHO classification? Paucibacillary and multibacillary. Treatment is depsone, rifampicin, and clofazimine. And bacillary index shows number of Mycobacterium leprae seen in a single view over a high power field. Thank you.